The next chapter is basically to describe how blood flow goes through the lung and what are some of the alternate mechanisms of the lung, which is metabolism. When you look at the actual perfusion that's going through the lung, it's pretty much all coming from the right ventricle, okay, which is 100% of its cardiac output. The right ventricle pumps into the lung with a very low pressure system because it has low resistance. Okay? There's a tremendous amount of surface area that's available, and only about 1/3 of the actual lung is actually being perfused at rest. So it has an additional capacity there for exercise to be able to accept the increase in cardiac output. Okay? The other thing about the pulmonary circulation is that there's really not that much smooth muscle in that area and the arteries or veins, so it really does not, it's not really a resistant system like the systemic circulation is. You can actually take the lung and flip it. You can actually take the arteries and veins and implant them backwards, and it would basically make almost no difference. Okay, so both sides have almost no difference in the sense of a smooth muscle. So reverse flow is actually very feasible to take place. Does reverse flow ever really occur? The answer is no. Okay? If reverse flow occurs, basically all all perfusion stops and you're basically dead. So that usually does not take place. Now, do you get partial reversal? And the answer is somewhat. When you get the mitral valve becomes incompetent, you can have some reversal in flow, but it's very temporary and it's only during a certain portion of the cycle. The pressures around the pulmonary blood vessels are important in the sense that it just decides where the blood's going to be shunted to. Okay? When you look at the actual architecture of the capillary and the alveoli, is that normally the alveoli have around them a very high density amount of capillaries. There's actually also a structure that's in between these capillaries, which is right here, which is called the extraalveolar vessel. The extraalveolar vessel is important when you have a very rapid increase in pressures inside the alveoli. If that were to take place, let's say you're doing a Valsalva maneuver, okay, that person that's doing that Valsalva maneuver exerts a tremendous amount of pressure increase at the alveolar level. And what that does basically is it collapses all the capillaries. In essence, if that were to take place and you had no other way of shunting the blood through, then that individual would have no perfusion to the left ventricle or the left atrium, and the person would basically have a cardiac arrest, which can happen. Okay? But under normal circumstances, that extraalveolar vessel allows for the shunting of the blood to take place. Now, when does this extraalveolar vessel get bigger? In the sense that it actually gets much more perfusion through very large lung volumes. Okay? And one of the situations that will happen is if you push a lot of volume into a patient, you will actually get a decrease in saturation. The reason you're getting a decrease in saturation is because you're actually taking the capillaries that allow the diffusion to take place and you're collapsing them, and now you're just shunting deoxygenated blood past through these extraalveolar vessels, and now getting them to systemic circulation, which will then subsequently you'll see a decrease in saturation. In essence, we do the same thing when we're actually doing what's called the vital capacity breath. Okay? If you see somebody who has atelectasis, let's say their saturations are 94 to 95% in the operating room, and you're running them around 50% oxygen at the time, you know that you have a certain degree of atelectasis going on. That person should be 100% saturated at that level of FiO2. So what you'll do is to re-expand the lung is you'll do what's called a vital capacity breath. What a vital capacity breath is, you'll close your pop-off. Okay? You'll take the bag, squeeze the bag till it hits 30 millimeters of mercury, 30 centimeters of water pressure, and you'll hold it for 7 to 8 seconds. When you hold it for 7 to 8 seconds, what you're doing is you're hyperinflating the lung. So you're going into this situation. So the first thing that you'll actually see is that the person's saturation will actually fall. The reason you're seeing that is because now the blood is shunting through the extraalveolar vessels, and the sats will begin to decrease by 4 to 5 millimeters of, 4 to 5 saturation points, okay, percentage points. Once you let go of the lung, the alveoli that are re-recruited now have 100% oxygen at the alveolar level, so oxygen uptake takes place very rapidly, And then after that, within 35 to 40 seconds, you see the saturation go to 100%. So it's a dramatic increase. So it's a good sign that you see a decrease in saturation initially, followed by a rapid rise in saturation. That really is indicating to you that you've really re-expanded the lung properly. Okay? If you don't see that desaturation, what that basically means is that your lung is stiffer than you think it should be, okay? And you really never went to the point where you have now exerted the volume recruitment and caused the extra-alveolar vessels to shunt the blood through it. Yes? 30. Right. 30 centimeters. Some books will actually tell you to go all the way to 40. That's fine. It's either 30 to 40. It's in that range somewhere in between. Most people are telling you just to go around 30 right now. Okay? But 40 is also what the study was also showing at. Okay? The extra-alveolar vessels are exposed to the pressure less than the alveoli and are pulled open by the radial traction of the surrounding parenchyma. Okay, so what you're seeing here is when the lung overexpands, it actually will put traction on the extra-alveolar vessel and pull it along. When you go the other way, which is when you're going above FRC, this is above FRC, this is what normal FRC point would be. So as you're going up FRC, if you over-distend the lung, your actual sats may actually fall. Okay? And you see this in people that have bad COPD. Okay? Bad COPDers are much more likely to have this problem. So as the lung increases above FRC, the pulmonary vessels outside the alveoli are distended and their resistance falls. On the other hand, the septal capillaries in the alveolar walls are stretched so their diameters are reduced. So this basically causes the shunting to take place at a higher rate. The net effect is an overall increase in pulmonary vascular resistance, since the narrowing of the septal capillaries is a dominant effect of what controls your vascular resistance. So increasing, over-distending the lung is not such a good idea in the sense of workload to the right ventricle. Okay? If you go below FRC, which is what you're seeing in the second portion here, and this is where the capillaries now are more distended. Okay, so as lung decreases below FRC, the pulmonary vessels outside the alveoli tend to collapse as their walls are no longer being stretched by the surrounding lung tissue, leading to an increase in their resistance. Okay? So reduction in alveolar size leads to a reduction in the stretch of the walls. And although the resistance to capillary decreases, the overall effect is an increase in pulmonary vascular resistance, since there's an increase in extra-alveolar vessels is the dominant effect in this situation. Okay? So both sides are bad. That's what they're trying to show you. The more important if you had to say which one is more likely to cause a rapid increase in pulmonary vascular resistance, it's over-distension of the lung. Okay? So you don't want to over-distend the lung. So PVR, which is pulmonary vascular resistance, is basically measured as a delta P, or the change in pressure, okay, which is an input pressure minus the output pressure, which is usually measured as your systolic pressure minus your diastolic pressure in your pulmonary circulation, divided by blood flow, which in this case is cardiac output. Okay. The lungs have very low resistances due to vascular changes. As the pressure rises, resistance tends to fall in the lungs due to recruitment of more capillaries. You get distension of blood vessels due to increasing pressure. Okay. It's mostly seen as high pulmonary vascular pressures as a consequence of that. Here's what you see, and this is what the system is set up for. Okay, you can either recruit or you can distend. Okay, recruitment basically means that you're going to recruit more blood vessels that are collapsed. Okay, distension basically means that you will take areas of the lung that are already being perfused and basically just dilate them up. Okay. The two mechanisms are for the decrease in pulmonary vascular resistance that occurs as the vascular pressures are raised. Okay. And different individuals have different capacities to do one versus the other. Most of the time, under normal conditions, it's recruitment that's a more important factor. Okay, if you look at your lung, the bottom surface of the lung is what's used at rest. So only about 1/3 of your lung is really being perfused. The rest of the upper portion of the lung would basically be very low in perfusion. As you increase the cardiac output, you're basically just going to continue to recruit up the lung. Okay? So that's one of the things that you'll notice. The lung volumes are large. There's large lung volumes, increased pulmonary vascular resistance by increasing capillary resistance. Okay, so that's not a good thing, which is what we showed you before. High resistance at low lung volumes is due to critical opening pressures. So somebody who is developing atelectasis, okay, is also going to have an increase in pulmonary vascular resistance. Either way you go, above FRC is not a good place to be for PVR. Okay? If you fully collapse the lung, PVR goes skyrocketing upwards. Okay? So if you have a bilateral pneumothoraxis, okay, you're going to have a very high pulmonary vascular resistance in that situation. Okay? That's what they're trying to show you. On the other hand, if you have bad COPD, one of the things that the person dies of COPD is cor pulmonale, okay, which is right ventricular failure. Okay? The reason they're developing right ventricular failure is because now they're over-distending the lung, okay, so PVR goes up. That's very dramatic in the sense that if you have somebody with long-term emphysema, you will see that they'll develop splenomegaly, they'll get ascites, and they will get peripheral edema. They don't necessarily get all with ascites, but they do get the peripheral edema that's pretty evident. Okay? So that would tell you pretty much that at that point that right ventricle is beginning to fail, and that's due to the very high PVRs due to this problem. So what this picture is basically trying to show you, the optimal place for vascular resistance is right at FRC, which is the bottom portion of this curve. That's where optimal FRC points are in this individual. If you go up or down, it's not good. The worst one by far is over-distension of the extraalveolar vessels. Now, the measurements of pulmonary blood flow can be done with what's called a fixed principle, okay, which is basically taking oxygen consumption measurements and dividing it by the pulmonary venous oxygen content minus the pulmonary arterial content. I don't basically expect you to know this equation. What I want you to basically understand from it is that you can measure pulmonary blood flow via shunt equations. Okay? The actual blood oxygen capacity is how much, we'll talk about this a little later on, of how much oxygen is actually being carried by the blood. Okay? And that becomes an important equation, which we'll come back to it later. Okay? And all these values can be actually done. This is something I don't ask you on the exam, but I want you to understand is this is a little bit complicated. And you can, if you want to later on when you get to clinical, if you want to measure pulmonary blood flow, you'd have to get certain kinds of values, and then we could actually do the shunt equation if you want to. Yes? It should be flipped around. For some reason, it was no. I'll have to look at that again and review that with you. Let me just get back to that. I got too much to cover right now. Just know that we're not going to cover this on the test. Okay? I don't go into this because it's usually higher level. You need to be able to understand first just how oxygen gets into the system and how pulmonary blood flow is actually getting around. The reason this is an important lecture is basically for you to understand the concepts of how blood gets through the lung. Okay? And if you don't perfuse the lung, no uptake takes place. Okay? And once you get into clinical, then we can come back and do all these equations and do all the actual calculations if you want to. Okay? But actually 99% of the time, guess what? We don't do these numbers. They're too complicated to get, and they're not reliable most of the time, believe it or not. Okay? Now, one of the things that I think is very important is for you to understand that the distribution of blood flow. Okay? How blood actually goes in the lungs and how it distributes is a very important concept. Okay? Why? Why is it important? Because you put in monitors. When you put in PA catheters, you have to understand how blood flow goes to the lung. Okay? You also have to understand how blood can be redistributed by gravity. Okay? So positioning patients can make a significant difference in your measurement in your PA catheters, as well as what is actually taking place in the lung. Okay? And you also have to sort of understand that the lung is not just a cylinder. It is actually shape-wise, it looks like a pyramid to a certain degree. Okay, the top, which is the apex of the lung, is actually a much lower surface area than your base. Okay, so the base is actually a much larger area, which means that we're really made to be upright, okay, to be standing or sitting most of the time. If you were a bat and you sleep upside down, guess what his lung's like? Okay, he's going to have almost equivalent levels on both sides. Okay, his lung actually on the top is actually bigger than a base. That's why he's more comfortable sleeping upside down. Bats have very different anatomy than us in the sense of how their blood vessels are set up so they don't get increases in ICP from that. But it's just interesting how they do have a different kinds of lung architecture because of the way they actually hang out. For us, in that sense, we basically are happier animals by standing up or sitting. Okay, that is our better surface area comparison for BQ. Now, what we actually call the zones of distribution is by calling them what's called the zones of West. When you're looking at the lung, you can separate out the lung into 3 zones. Okay? The upper zone, middle zone, and lower zone, also called zone 1, zone 2, zone 3. So when we're talking about that, that is dependent on somebody right now that is standing up. If I flip you upside down, in other words, I put your head down and hang you by your feet, okay? Then zone 1 would be at the base, zone 2 would be in the middle, and zone 3 would be at the apex of the lung, upside down. So this description is based on gravity, okay? And the position is based on where blood flow is going to be. Zone 3 is where most perfusion takes place. Okay, the base of the lung is where all the blood's going to go. Okay, so that's zone 3. That's what we call, there's 3 designations that we use for these zones. We're going to designate them as the alveolar zone, the arterial zone, or the venous zone, okay, which are basically applied by the following. Alveolar zone is P big A, okay? And that's the actual pressure inside the alveoli. P little a is the actual pressure inside the arterial side. And P little v is your venous pressure. In zone 3 of the lung, which is the base of the lung, the arterial pressure is greater than the venous pressure, which means the blood flow is going from artery to vein, which makes sense. And the actual alveolar pressure is actually lower than the venous pressure. So perfusion is always constant in zone 3 of the lung. Okay, so perfusion is always constant in zone 3 of the lung. If you look at zone 1 of the lung, okay, which is the top of the lung, you have alveolar pressures there that actually exceed arterial pressures. So if something exceeds the pressure of another, what happens to flow in that situation? It goes to 0. Okay? So at the top of the lung, there's no perfusion. None. 0. Okay? So the alveolar pressure is actually greater than the arterial pressure, which is then greater than the venous pressure. But all these veins and the arteries are both collapsed at the top portion of the lung. The middle of the lung, which I'm going to show you a picture of that in a minute, is called the Windkessel area. Okay? Windkessel. Okay? A Windkessel is what they use in Germany as what's called a watermill. Okay? Have you ever seen a watermill? Know what a watermill is? Watermill is basically, it has like 6 arms on it. Okay? It could have more. Okay? And at the end of each arm, it has a bucket. Okay? And the water pours in like a waterfall into the bucket. And once the bucket fills up with enough water, it has enough weight to throw the arm. And it throws it to the next one, the next bucket. So it's what's called intermittent flow. So, and that's why zone 2 is also called intermittent flow area. Okay? It's an area where you get intermittent perfusion. Okay? In zone 2, the arterial pressure exceeds the alveolar pressure, but the alveolar pressure can intermittently be greater than your venous pressure. So in essence, the veins are collapsed, so perfusion stops. So intermittent portions of perfusion are taking place in zone 2. Now, why is this important? The reason this is important is because very soon you're going to be putting in pulmonary artery catheters, and you have to understand this concept. Okay, and I'll show you this in a drawing in a second. First, this is a nice picture showing you how distribution of blood is actually taking place. In zone 3, which is the bottom portion of the lung, you can see the blood flow is very high, which is the maximal blood flow. Remember I told you most of the blood flow is occurring in the 1/3 of the surface of the lung, which is the bottom portion. This is what they're showing you here. The upper 1/3 is zone 1, and it shows you that there's no perfusion at all. Perfusion and blood flow has gone to 0 at that point. Okay? And you can see as you go down into zone 2, as you approach more zone 3, there's more improved blood flow. Okay? But at the top of zone 2, you can almost go to 0 perfusion because at that point you're getting very close to alveolar pressure exceeding arterial pressure. This is zone 1. This is to reiterate what I was talking about before. Alveolar pressures are greater, both local pulmonary artery and venous pressures, and the vessels are compressed. Basically, there's no blood flow in that situation. Okay, so this is completely 0 flow here. In zone 2 is Windkessel area, which is it's called the vascular waterfall. Okay, as the flow is independent of the eventual venous pressure, and depends only on the difference between the pulmonary arterial pressure and the alveolar pressure. And then zone 3 is the area of constant perfusion, which is down here. Okay, you can see that this graph is showing you high blood flow to this area. Now, what happens clinically when you're putting a PA catheter? Okay, we'll talk about that. And the other thing is that what are the effects of ventilatory management? Okay, if you overventilate somebody, okay, in other words, you give somebody a very large tidal volume, what essentially happens to zone 1? Does it decrease or increase? It increases dramatically. Okay? Zone 1 is the area where you don't get perfusion. So if I give you more tidal volume, that means that I'm going to cause more volume to get in the alveoli, and that's going to exert a greater pressure inside the alveoli. So in other words, if I give somebody a really very big tidal volume, let's say 2 to 3 liters, and if I don't cause the lung to collapse in the sense of a rupture, then at that point, with that much overdistension, all perfusion stops, and that person will arrest on me. So you can actually kill somebody by overventilating them. Okay, is it possible? Not likely. There's a lot of things that are safety mechanisms that we have in place, but you can do it if you really push it. Okay? So essentially, if you increase alveolar pressure higher and you exceed the arterial pressure in the pulmonary circulation, you will stop all blood flow through the capillaries. Okay? Now, the other thing that's important about understanding this is when you put positioning of patients, and we'll get into this in your second year when you get into clinical, but when you tell people that you're putting them in lateral position, it makes a big difference that you have to understand that zone 3 of the lung is going to be the downside. Okay? That's where most perfusion is going to take place. Okay? Now, as we get into it further, we're going to talk about how FRC will definitely affect how ventilation is taking place. But right now, we're just talking about perfusion. Get down in your mind first, where does perfusion go? It goes basically where gravity goes. It's always gravity dependent. So it always goes to the downward dependent portion of the lung. Okay? Now, what about PA catheters? Let's say you put a PA catheter in a patient. Okay? If you put a pulmonary artery catheter in an individual, and you put the person like this, okay, upside down, okay? And the reason you're putting it in a person like this in Trendelenburg is because in that individual, okay, the neck veins get distended, and you're able to insert the cannula much more effectively. Okay, that works great. That's what you're supposed to do. Now, before you put the PA catheter in, though, you're supposed to do one more step, which is what everybody forgets, okay, which is take the table and flatten it. Okay? If you don't flatten the table, you will put the PA catheter in. Okay? Let's say this person was difficult to put in the PA catheter. Let's say he had bled out a lot, and now you had to put him into this kind of position to get the PA catheter in. So they're literally almost upside down. Okay? And you may laugh, but it's actually, sometimes you have to do that. Sometimes you get really desperate. Okay? And then if you look at, and you start floating in your PA catheter, where's zone 3? There's zone 3. Now, where will the PA catheter always go? Does it go to zone 1, zone 2, or zone 3? It goes to zone 3 because it's perfusion dependent. Okay, PA catheters float based on perfusion. Okay, so they always go to the right, okay, because 60% of your perfusion goes to the right lung. So that's why you see always PA catheters on the right. Everybody says, oh, it's because the catheter is bent that way. It's not, it's had nothing to do with that. It's simply because flow is higher going to the right. Okay? Now, if you see a PA catheter going to the left, it's a diagnosis of pulmonary embolus until otherwise proven. Okay? That should be pretty much on the top of your list, or pneumonia or something that's going on with the right lung. Anyways, so if you put the PA catheter in, now the catheter's here. Okay? So it's in the apex of your lung. So now during the case, I take that individual, and because the surgeon now says, you know, I want you to put him in, and you've resuscitated him a little bit. Now he tells you to put the person up like this, in reverse Trendelenburg. Now your zones are like this. 1, 2, 3. Where's your PA catheter at? It's right here. It's in zone 1. That's going to cause you a problem. Okay? What's the waveform going to look like? Dampened? Nope. Close, but not dampened. What you'll see on your PA waveform, the PA waveform should look like this. A, C, V, A, C, V, A, C, V. We all agree, right? What you'll see in this individual, you'll see this. Why that? That's right. That's a ventilator firing. Now, here's the bad thing. What's your normal mean airway pressure for most individuals? 15 to 20. What's your normal PA occlusion pressure? 15. So you're going to think everything's fine and dandy, even though the person could have a real value of maybe 3 or 4. And now you're not going to resuscitate him adequately because what you're measuring is not blood, what's inside is taking place. We're not measuring the left atrium anymore. You're actually just measuring intra-alveolar pressure. Okay, so that's because you're measuring zone 1. Now, if you were looking at zone 2, okay, you would get a slightly different appearance. Okay, this is what you would see if you put it in zone 3. This would be zone 1. And if you had somebody in zone 2, you would get the following. A, C, V. Okay. Why is this? Intermittent ventilation. You see the ventilation pattern show up. All of you have seen this, and you just didn't know what you were looking at in the ICU. If you have a PA catheter in someone, you put an occlusion pressure up, and you saw this, how many of you would recognize that it was really, what has happened to your catheter? Okay, let me just go back. Let me just give you a different clinical scenario. It'll make more sense. We'll leave this guy in. When you originally did your PA catheter, you did it right. Okay, here's your patient. Okay, you laid him flat. Okay, so his zones. This is zone 1. This is zone 2, and this is zone 3. Okay. When this individual, when you put this PA catheter, it went to the right place and went right here to zone 3. Okay. Now, during the night, the patient blew out, let's say, a vein in his abdomen. Okay, so now he's been leaking blood all night. Okay, and your blood pressure's come down a little bit. Okay, and very soon you start seeing this show up on your PA occlusion pressure. unfortunately for you is that you don't know what you're looking at. So what the machine does for you is that it takes the mean and it tells you 15, when in reality you're down here, which is actually 7. And you went from 15 here down to that. So now you're going to miss that the person's hypovolemic, because you're going to believe that the machine is giving you a good calculation. Okay? Now, why is it that you're going to this kind of pattern? And the reason being is as your blood flow begins to, as your venous return begins to decrease because you're bleeding out, the actual surface area of the lung now that's being perfused is only here and partially here. So your PA catheter now shifted, so now your zone 3 is actually down here. This is your new zone 3. So you're actually ventilating, sorry, you actually have your PA catheter in zone 2. And that's why you see this intermittent ventilation pattern because the person's bleeding out on you. Yes? That's right. That's correct. But you see, what's really important for you to know is if you had this pattern on the top and it switched to that, now that you know that, hey, there's something bad happening in the lungs. I'm not perfusing anymore. There's something, I'm either not getting performance of the ventricle is not pumping, or I'm not having enough volume anymore getting to the lung. So there's two reasons why the volume's not going to get to the lung, either low preload or low contractility. Which one is it? And so you shoot a cardiac output. Cardiac output would show that stroke volume's still okay, but the preload's low. So you give volume, and all of a sudden the waveform changes back, and everything's fine. Okay? Yes, sir?
Question, to clarify, you said, where exactly is the end of the PA catheter?
The PA catheter, once the PA catheter gets inserted, it does not move. It does not refloat itself. Okay, the only time you refloat the catheter is you have to pull the catheter back into the pulmonary artery and then refloat it. And then it'll go down to zone 3 again. Okay? But basically the PA catheter always goes to zone 3. It's just flow dependent. Make sense?
So the tip is clear down there and the vasculature is the base.
That's correct. Okay? That's where usually you'll find it. When you do the chest x-rays, that's where you'll see it. You always see it. And when you look at a chest x-ray, the PA catheter will look right here. So it gives you this idea that it's in the middle of the chest. That's because the person was laying down. But when you do a lateral shot this way, the PA catheter is actually sitting almost posteriorly because it's going in the zone 3 area. Okay? If you were to put the PA catheter with the person sitting up, where would the catheter be? It would be down here. Okay? Every once in a while, you'll see that the PA catheter is up here on the x-ray. What do? The person that was in deep Trendelenburg when they put the PA catheter in. So you can actually tell exactly at what position the patient was in when they put the PA catheter in. Okay? Does it help? Okay. Next concept, dead space and shunt. Okay? One of the things that when you start ventilating and then you have to have perfusion, you can have a correlation. And that correlation can be described in one or two ways. One way is where you don't have perfusion at all, and that's considered dead space. Okay? Or an area where you don't ventilate anymore, but you're having lots of perfusion, and that's called shunt. Okay? Either one is bad, but by far the worst one is shunt. Okay? Shunt is the most dangerous one that we have to deal with because it's very difficult for higher FiO2s to actually treat it. So if I have a choice between dead space issues or shunt, I'd rather go into dead space problems because they're more easily to manage with increasing FiO2s. Versus shunt are very difficult to treat with increasing FiO2 levels. Okay? So what you look at is the equation, the way you look at it is, imagine that you have an alveoli coming in and you have blood flow going through it. Okay? This should be at 1 for every one of coming in. Okay? So that's my V over Q. Ventilation over perfusion. The optimum will be a 1-to-1. That would be ideal. That means for every one part of ventilation, I get 1 part perfusion, and that means that's going to give me the best way of uptaking and removing any kind of gas. Okay? If I have dead space, in dead space, this value here is basically staying steady, staying at 1, but this value in the perfusion level is beginning to fall, 0.0001. Okay? Now, I don't know what infinity is, and nobody can ever explain to me what infinity is. Okay? Because if somebody tells me, well, imagine between here and the Milky Way, the end of the Milky Way, I said, well, what about go to the next constellation? You know, it's like it's not a number that you can sort of put your hands on, because no matter what you think of, it's another number bigger than that. So I hate the concept of infinity. Instead, what I do is I do it mathematically so it makes sense to me, which is I just take a low number, let's say 0.1, which is lower perfusion, and then go to 0.01. Every time you go to a lower and lower denominator, what happens to your overall number? It goes up, okay, which is what they're saying it goes to infinity. So when you're seeing that the perfusion is very limited, the actual number that you get is actually very large. Okay? Versus if you think of 0, and that's what they usually put in the books, they always put the number 0. I don't know what that means. 0 over 1, it doesn't make sense to me. What they're trying to tell you is when you're approaching 0, the closer you get to it, which is 0.00000000000, way 1 all the way down, that's as close to 0 as you can get. As you're approaching that value, the overall number is going exponentially vertically upwards. Okay? Does that make sense? Instead of doing the 0 thing, which I can't really understand. Versus the shunt. Shunt, on the other hand, is a person that is no longer getting perfusion, okay, or very little. So that value goes on the top. Sorry, no more ventilation. So that value goes 0.0001 over 1. Okay? So the overall value is going towards 0. Okay? So 0 over 1 is 0, essentially. And that's what we call shunt. Shunt means that the area is no longer being ventilated, but you're still perfusing it. Okay, what's an example of shunt? Main stem intubation. That's a shunt. Okay? If you main stem intubate most people, it's going to be on the right lung. That means you're still going to get 60% perfusion with 60% ventilation. That means you're going to have a 40% shunt. Okay, can you hide that with high FiO2s? The answer is you can, but it's not as easy as you think. If I main stem somebody and then their saturation falls down to 90%, and I increase the FiO2 and it comes back to 98%, that means to me that that person's not responded to oxygen that much. Okay, that person with 100% FiO2 should have hit 100% saturation. And we'll come back and explain that in the next lecture next week, so it makes more sense for that. Now, the actual control of circulation is by a specialized mechanism called HPV, which is hypoxic pulmonary vasoconstriction. HPV tends to be controlled at the lung level. Okay? The book says that essentially that the neural status is really not that important. I would hate to differ with the book, but I think it is important. Okay? But it's not dependent on the central nervous system. Maybe, maybe not. If you've ever taken care of somebody with severe neurological damage, I can tell you the HPV goes completely out of whack, and you have a very hard time basically giving them enough oxygen to keep them alive. Okay? Because what you're doing is you're waiting usually for transplantation, so you have to fight to get oxygen in these individuals. The reason that you're losing that is HPV becomes affected. So the book I don't think is right. Okay? And I've got some other, but we'll test you based on the book. Okay? So the book says not dependent on CNS, okay, which is, it is mostly not under normal circumstances. Most of the time, what the sensors are available at the lung level is just measuring alveolar oxygen content. okay? And when alveolar oxygen content falls in that area, what will happen is the smooth muscle will vasoconstrict and shunt the blood to areas of higher alveolar oxygen content. So HPV is very useful to try to maintain a good VQ match, okay? We think it's probably due to direct effects of low PaO2 on the smooth muscle causing it to contract. It's one of those things that is really critical at birth and transition from placental to air breathing. When you take in your first breath of air as a child, okay, that first breath definitely kicks down the HPV and allows for the blood to basically shunt through the lung once again, okay? Under normal circumstances in a neonate, 80% of blood never goes through the lung at all. Okay, it goes through the PFO, the foramen valve. But when you take that first breath, HPV falls dramatically, allowing for blood to now go through this pulmonary circulation. Do you ever get that tight in your lungs again? The answer is no, unless you're in situations like ARDS, which are very dangerous to be in. Direct blood flow away from poorly ventilated areas of diseased lung in the adult is usually what's also taking place, which is kind of good, okay, which is trying to help maintain adequate oxygenation in you at all times. The other thing that's important, and we'll talk about later on, is water balance. There's 2 stages of pulmonary edema that takes place. Stage 1, the capillary will leak into the interstitium. Most of the time, the lymphatics will take over and extract this. The next place where it actually goes into the interstitial space, it goes into the peribronchial space, causing perivascular edema to develop and peribronchial edema. So these people will start showing signs of expiratory wheezing. So if you're listening to your precordial stethoscope in the operating room and you've just dumped like 3 liters of fluid in the patient, and they all of a sudden start developing, expiratory wheezing, please don't think it's asthma. What you're dealing with is you're now dealing with early forms of congestive heart failure, and you need to treat it as such. Okay? The way you would treat it was usually give Lasix, give positive pressure ventilation, and maintain PEEP in that individual. But then you want to extract it, so Lasix is the right treatment. Okay? If you continue pushing fluids on that individual, you'll overwhelm the system, and you will start causing leak to go up from the interstitial space into the alveolar space, which is normally dry. When that occurs, you'll see, depending on how severe this leak is, if it's just minor severity, then it'll actually leak just fluid, and it'll basically you get frothy white sputum. If you start seeing frothy red sputum, that's really bad, because what that shows is a disruption of the capillary wall, and now you're allowing red cells to actually extravasate all the way through into the alveolar membrane. So that's usually only seen in things like pulmonary contusions, although I have seen somebody do that was actually 24 years old from negative pressure pulmonary edema. They actually disrupted the capillary membranes just from them biting down on the endotracheal tube and causing a very deep inspiration taking place, and they disrupted and caused flash pulmonary edema to take place. Not good to see. It's treatable, but something you will get into later on as we go through this. The other functions of the lung is that it also acts as a reservoir. When you suddenly lie down or after standing, quite a bit of venous return that's in the leg drains directly into the right atrium. The right ventricle then pumps the extra blood into the lung, but not all immediately moves to the left ventricle. Some of it is actually stored in the lungs, which gives the left ventricle a chance to compensate. It prevents cardiac output from increasing excessively as one goes from an upright to lying down position. On the other hand, when one goes from a lying down to an upright position, okay, the stored blood in the lung now flows to the left atrium, helping maintain cardiac output long enough for the baroreceptors to initiate compensatory mechanisms. So the lung definitely acts like a reservoir and helps the left ventricle undertake different positions. Where this becomes important is in pathophysiologic states where you'll say you remove a lung, okay, where you have a person with only one lung, let's say you do a pneumonectomy. These people are much more symptomatic when they try to get up really quick. They get, they get lightheaded, and people don't remember this concept, and they forget about this, and they think, well, the person needs more volume. And the answer is, it's just partly because they don't have lung capacity to have enough of a reservoir. The only thing you can tell those patients to do is don't come up as fast when you sit up. Go a little slower, and then usually it's more than enough to take care of them. giving them more volume will tend to cause the lung to get more heavy, and you could put that person in flash pulmonary edema pretty easy. The other function of the lung is acts as a filter. It basically filters out air, okay, that may entrain in your system. It also filters out clots, okay. It also takes most of the clots that get into your venous side and eventually reach your pulmonary circulation are usually broken down and you never perceive it. But if it's a large enough clot, then you develop what's called a pulmonary embolus and can cause death. Okay? But small clots would cause coronary or cerebral embolism if it transfers from the right to the left. So patients that have patent foramen ovales, which is around 20 to 25% of individuals, can have that take place. So the lung has a very important function in that respect. The other thing that the lung has is it has a significant metabolic function, which a lot of people don't think of. It has significant effects on arachidonic acid metabolites, such as prostaglandins and leukotrienes. And this is becoming an interesting field in the sense of discussion of asthma. There's a certain kind of metabolism that takes predominantly place in patients with asthma that we are now beginning to learn how to interfere with. So hopefully some of these medications that are coming down our pike will help control asthma much more at a metabolic level. The type 2 alveolar cells make the actually pulmonary surfactant, which is essential for normal lung compliance. Without surfactant production, the lungs would fully collapse between every breath, which would not be a good thing. The other thing that pulmonary surfactant also adds is it has antibodies in it, which are important as protectors against infections. The other metabolic function of the lung, of course, is converting enzyme, which is ACE, angiotensin converting enzyme, which takes angiotensin 1 and converts it into an active form of angiotensin 2. It converts active bradykinin into an inactive metabolite as well. So there's different things that are readily available for you. You can either activate or inactivate. Epinephrine is also inactivated by the lungs as well. The lungs also make a tremendous amount of immunoglobulin A, which provides a defense mechanism against pulmonary infections. You can see some kids come in with recurrent pneumonias all the time, and one of the things you've got to consider right then and there is that they have immunoglobulin A deficiency in production in the lung. The upper airway secretes mucus, which is essential for removal of inhaled particles, which is also part of like cystic fibrosis, where these individuals cannot perform and provide an adequate soil level solvent layer. Also, the lung removes serotonin from the blood, which may be transferred to platelets, and the lung can partially remove or inactivate norepinephrine and epinephrine. So all these are pretty extensive things that the lung is doing. The last thing it does for metabolic-wise, is prostaglandin E2 is produced by the lungs of the fetus. They serve as basically smooth muscle relaxants, keeping the ductus arteriosum open during fetal life, and that's where it's important when we talk about pediatrics. Once you're born, PGE2 levels fall dramatically, and then the ductus arteriosum begins to close. So one of the things that we do is to keep this open is to give inhibitors of prostaglandin synthesis, which is indomethacin, can be administered to facilitate closure of the ductus. If you want to keep it open, then you keep administering PGE2 to this individual. Okay. So they have different